Good morning, ladies and gentlemen. I'm honored to have been invited to speak at this conference. My name is Jing Xie, a PhD student from Harbin Institute of Technology. Today, my topic is learning an expandable EMR-based medical knowledge network to enhance clinical diagnosis. The content of this presentation is divided into 5 parts. First, I will introduce the intelligent diagnostic systems. According to our research, the most of intelligent diagnostic systems only consider the patient's features and use classification models to make disease diagnosis, which rely on a mass of electronic medical records. And these black box models are not very convincing for both physicians and patients. To solve this problem, we consider using medical knowledge to support decision-making. In addition, using medical knowledge to make decisions can reduce the dependency on training data distribution and improve the robustness of the diagnostic models. A commonly used model to organize such relevant knowledge is to construct a medical knowledge network. So, what is a medical knowledge network? A medical knowledge network contains a set of medical knowledge to link medical concepts, a learning method to estimate the effectiveness of each knowledge, and an inference mechanism to make disease diagnosis. However, the most existing medical knowledge network extract knowledge from a single resource, such as biomedical tests, human annotated databases, or electronic medical records. That is because recognition and extraction models rely on rich features of context information and requiring sufficient training data. Besides, many new terms and knowledge keep appearing. The quality of the diagnostic result made by MKN-based clinical decision support system depends on the accuracy of medical knowledge and the complexness of the network. Thus, we propose an expandable EMR-based medical knowledge network. Here, we introduce 2 related works. The first is knowledge integration. Knowledge integration is the process of incorporating new information into an existing body of knowledge. There are 2 integration levels. The first is entity layer integration, which is regularly using controller terminologies, such as UMLS. However, it is missing in Chinese. The second level is knowledge-based integration. Some prominence information, such as the credibility of knowledge sources and the frequency of knowledge, is often used to determine whether the target knowledge is true. However, knowledge is inconclusive. Some knowledge is inconclusive. For example, it's recorded in textbook that the symptom vision disorder indicates the happening of disease diabetic retinopathy, but it might also indirectly indicate the happening of disease diabetes. So our network needs to deal with this complex network knowledge. The second work is mining hidden relationships. Mining hidden relationships in an existing network is considered a link prediction task, which is often applied to social networks, biology, and drugs. However, it has not been researched in clinical reasoning. Here, we can determine the relations or interaction between nodes by the similarity of their nodes and paths. Now, I will introduce our methodology. First, we construct an original MKN. We construct our original MKN based on Chinese electronic medical records, which comprise detailed introduction about patients, such as their admission, diagnosis, and conditions, treatment, procedures, and effects, as well as other information in the normative expression. So we have drawn the Chinese annotation guidelines for the CMRs with the assistance of the medical expert and manually annotated named entity and entity relationship of 992 CMRs. The entity is classified into 4 categories: diseases, symptoms, tests, and treatments. The announced indicate relations between disease and symptom entities are defined as the medical knowledge, which states that the patient's symptoms indicate the related disease. This picture shows our original MKN. The green nodes are disease entities and the red nodes are symptom entities. If a symptom indicates the disease happens, they will be connected. Next, to quantify the effectiveness of indication relationships, we drive the weight of each piece of knowledge based on the Markov knowledge network theory. According to this theory, the joint distribution of our original medical knowledge network is formulated by this function, and the possibility of the node is calculated by this. All weights are learned by maximum likelihood estimation. After construct original MKN, we propose an incremental expansion framework. The expansion framework is divided into 2 parts. The first is integrating external knowledge extracted from the medical information website. The second part is mining potential knowledge in the existing knowledge network. After integrating and many procedures, we obtain new knowledge and the candidate weight. A diagnosis-driven learning method is used to update all weights in the MKN. Here is the workflow of our framework, and we will introduce step by step. The first part is integrating external knowledge. The first step is extracting external knowledge. External knowledge reflects the exact causal relationship between medical entities, while the EMR-based knowledge only indicates the empirical relationship in the process of clinical diagnosis. As we mentioned about, our original medical knowledge network is constructed by EMR-based knowledge. So we obtain the external knowledge from the medical website eMedTong by predefined rulers. The second step is nominalization of medical entities. We mapped all disease entities to international classification of disease and maintained a symptom vocabulary dictionary. The third step is calculating the trustworthiness of the candidate knowledge. We calculate the relevance of a pair of disease and symptom by their cosine similarity in guidelines by this function. And the last step is integrating external knowledge with original MKN. We follow the rules of that the knowledge is first if it is first in every medical resource, and it formulated like this. The second part is mining potential knowledge. The mining procedure aims to find more indication relationships between those entities which have been contained in the network but not have been connected. So the first step is mining potential connections. For a valid connection Si to Dj, if a path Si indication Di indicates Sj, and finally indication Dj exists, we can see that Si indication Dj might be connected directly. After mining potential connections, we calculate the connection possibility of each potential connection by case index, which is formulated by this. Here is an example of potential connection mining with a CEMR. We connected the blood patient to hypertension as a potential connection because there are two neighbors. These two neighbors are connected directly. So we can get a list of potential connections and their candidate weights. After integrating and mining procedures, a diagnosis-driven learning method is used to update all weights in the network to reduce gap between the doctor's diagnosis and the inference result. The training object is formulated like this, and it's clear that the weights of knowledge supporting the true diagnosis are gradually increasing. while those of other relevant knowledge leading to false diagnosis are decreasing in the iteration process. Here is our expansion framework, and we conduct some experiments to prove its effectiveness. The first is quantity statistics. We compared four medical knowledge networks about their knowledge amount and other metrics. And this is the result. The figure shows that the integrating procedure imports more kinds of entities to enrich the original MKN, while the mining procedures imports more hidden connections. The figures also show that the expandable MKN is more complete. We also compare the disease diagnosis performance about different models. This is the result, and it shows that the diagnosis performance metrics of 4 MKNs are higher than classical machine learning methods such as logistic regression, Navy-based SVM, and the neural network. The figures also show that the integrating and mining procedures improve 3 diagnosis performance metrics, and mining procedures contributes more valuable knowledge in disease diagnosis because it has improved the most. Finally, we come to the conclusion. We proposed an expansion framework of EMR-based MKN from 2 aspects. The first is integrating, and the second is mining. We extracted symptom indicate disease relations from the medical website as external knowledge and integrated them with the knowledge in the original MKN, and utilizing prior knowledge in the existing MKN. We also mined hidden connections as potential knowledge and estimated their connection possibilities reference to CAS index. Finally, to update the weights of all knowledge, we drive the diagnosis-driven learning method. So here is our work, and thanks for your listening.